Today I will be presenting the results of seroprevalence and retrospective mortality surveys conducted by Epicentre and MSF alongside partners in 3 different African contexts. Africa, which is approximately 17% of the global population, makes up only around 2% of global COVID cases and 3% of COVID deaths. Although the COVID situation has not been homogeneous across the continent, several factors have been proposed to explain the low numbers of cases and deaths, including the younger population, exposure to other circulating viruses in the region, and weak surveillance systems. Seroprevalence and mortality estimates that are thus necessary to help understand the global COVID context and to guide public health decisions. Since late 2020, several seroprevalence surveys have been conducted in MSF intervention context, including population-based seroprevalence and mortality surveys in Sudan and Kenya. As far as we know, these are the only studies combining mortality and seroprevalence surveys. Today, we will focus on 3 of the most recently conducted surveys, those done alongside among the general population in the entire country of Cameroon and the cities of Abidjan, Côte d'Ivoire, and Lubumbashi in the Democratic Republic of Congo. All done in mid to late 2021, more than 1 year after the first confirmed COVID case in each country, we aim to estimate both COVID seroprevalence and retrospective mortality during the pandemic. All 3 studies were adapted based on a generic Epicentre protocol that was created at the beginning of COVID. Each of the studies consisted of a retrospective cross-sectional household mortality survey with a nested seroprevalence survey done in a subset of the included households. The study in Cameroon was countrywide, including all 10 regions. In Abidjan, 2 communes were selected, and in Lubumbashi, 3 health zones were included. Here we can see the epicurves for each of the included countries. DRC on top, Cameroon in the middle, and Côte d'Ivoire on the bottom. In Lubumbashi, DRC, and Cameroon, the studies were both done after the second COVID wave. In Lubumbashi, May to April, and in Cameroon, in July to August. In Abidjan, Côte d'Ivoire, the study was done in 2 phases due to a suspected Ebola case, and thus data collection was ongoing during, in July and August, and also after the 3rd wave, in October and November. COVID vaccination campaigns had already started in Cameroon and Côte d'Ivoire prior to the start of the survey, but had not yet begun in Lubumbashi. For all selected households, the head of household or a representative was asked a series of questions regarding demographic characteristics of the household and a series of follow-up questions on any deaths reported in the household. Each study included a baseline period prior to the start of the pandemic and a COVID period. A subset of the households included in the mortality study were also asked to participate in the seroprevalence study. This consisted of interviews with all household members or their parent or guardian. Each survey used both rapid serological tests and laboratory-based serological tests. Each of the sites used different laboratory-based tests. While some available tests detect infection-induced antibodies only, all tests used in this study detected both vaccine and infection-induced antibodies. More than 12,000 households were included across the 3 mortality surveys, including more than 57,000 people. Here we compare all-cause mortality rates per 10,000 persons by period, pre-pandemic and pandemic, including all age groups. The pre-pandemic mortality for each survey is shown in yellow with confidence intervals, and the mortality during the pandemic is shown in blue. In Cameroon and Lubumbashi, we observe an increase in estimated mortality during the pandemic compared to pre-pandemic. Khartoum, incidentally, also observed similar results in a previous study. In both sites, the estimated increase was more pronounced in the 2nd wave compared to the 1st wave of COVID. In Abidjan, the only survey done that included the 3rd COVID wave, an increase was observed only during this 3rd COVID wave, but no significant increase was observed overall in mortality. All mortality rates remain well below emergency thresholds commonly used in humanitarian crises. Here we explore further the mortality rates stratified by specific areas included in the survey. While in Cameroon, both high COVID transmission and low COVID transmission areas had significantly higher mortality during the pandemic, in Lubumbashi, the stratified analysis indicates that only one of the two areas had significantly higher mortality during the pandemic period compared to the pre-pandemic period. In Abidjan, as seen in the overall analysis, no significant increase in mortality was observed in either area. Looking at estimated mortality among older people, 50 years and older, while in Abidjan there's again no observed significant difference, in Lubumbashi we observe a moderate increase, and in Cameroon the estimated mortality is almost 3 times higher during the pandemic. Almost 60% of deaths in Cameroon and Abidjan were 50 years or older. In Lubumbashi, where this older population makes up about 7% of the population, lower than the other two sites, about 30% of the total deaths captured were in this age group. While a large proportion of deaths are among older people, other age groups also experience significant increases in mortality, not shown on this slide. Moving on to seroprevalence results, we included almost 10,000 people across the 3 sites. While refusal rates for the mortality surveys were generally low, more than 50% of households refused to participate in the seroprevalence study. Cameroon had the lowest estimated seroprevalence, with laboratory-based testing, about 1 in 5 people tested positive. In Lubumbashi, almost half of the population was estimated to have COVID antibodies according to laboratory testing. Abidjan had the highest seroprevalent estimate regardless of test used, ranging from 35.6 to 79.4%. The impact of the third wave can be seen with the increase observed between the 2 phases, and is particularly evident with the rapid test results, which more than doubled in the second phase from 22.1 to 47.6%. Seroprevalence estimates with laboratory-based testing were 2 to 3 times higher than rapid serological estimates. To estimate infection-induced seroprevalence, we also excluded those who had already been vaccinated against COVID. While the results are not presented here, the results are similar with only small declines in overall seroprevalence. We present here seroprevalence estimates by age group, with rapid serological testing estimates on top and laboratory-based testing on the bottom. Among the sites, seroprevalence generally tends to increase with age, particularly in Cameroon and Lubumbashi, with similar trends regardless of the test used. The trend is less obvious in Abidjan. In all sites, the population aged 50 years and older has the highest, or among the highest, seroprevalence estimates. Infection to case ratios are helpful to determine the proportion of undiagnosed COVID infections. While we should not expect this ratio to be 1-to-1, particularly due to a high proportion of asymptomatic cases observed in general with COVID, it can identify areas with insufficient testing. Using surveillance system data from the specific communes and health areas in Lubumbashi and Abidjan, and the national data from Cameroon, we estimated infection rates tens in Cameroon and Abidjan to hundreds in Lubumbashi of times higher than the confirmed cases. Finally, we linked the results of the 2 surveys together to see if there was any association between the households that had at least 1 person seropositive and those reporting deaths during the pandemic period. Here we can see the proportion of deaths among households with and without at least 1 seropositive person in the household. Regardless of type of test and across all sites, we observed no significant association between seropositivity in the household and deaths. The main findings are, we observed an overall increase in all-cause mortality in Cameroon and Lubumbashi, driven largely by an increase in deaths among older populations, but increases were also seen among other age groups. This suggests direct and indirect impact of COVID and the pandemic. In Abidjan, an increase was only observed in the 3rd wave. This is consistent with the results of the COVID surveillance system in Côte d'Ivoire, which showed a greater increase in COVID-related deaths in this 3rd wave compared with previous waves. Neither Cameroon nor Lubumbashi captured the 3rd or the subsequent 4th wave. The seroprevalence results show that the virus has circulated widely, with estimates 10 to 100 times higher than the attack rate captured by the respective surveillance systems. This suggests underdetection of cases, particularly in Lubumbashi. All three studies estimate highest seroprevalence among the older population, regardless of vaccination status. These findings are similar to earlier studies done by Epicentre, MSF, and others in Africa, and contrast with studies done in other parts of the world, in which seroprevalence rates are generally lowest among older populations. This is concerning, of course, because older people are at higher risk for complications and deaths, and suggests that targeted vaccination campaigns may be appropriate in some settings to protect these higher risk populations. As with any retrospective survey, there is a risk of recall bias due to the long recall period of all three mortality studies. The seroprevalence studies in particular faced high rates of refusals, suggesting a risk of selection bias. Finally, in addition to the timing of the study and the possibility of cross-reactivity, trends in antibodies following infection are highly dependent on the assay used. This is highlighted in the presented studies by the differences observed between rapid and lab-based results, and remains true also when comparing the results between the different sites. Due to antibody waning, the present studies and other studies likely underestimate the true extent of past infection. Lastly, as mentioned, 2 of 3 sites did not cover the third wave, and none of them covered the fourth wave. Finally, I would like to thank all of the investigators for their participation in these studies, including our partners at the Ministry of Health and the laboratories used. And in particular, I would like to thank Birgit, Nikolai, and Etienne. These studies would not have been possible without the hard work of the project and survey teams, the community stakeholders who help support these works, and the community members who, of course, agreed to participate in these studies. Thank you very much.